All right, good afternoon, everybody. Let's get started. This is an important topic, and we wanted to give everybody adequate time and give Dr. Amsterdam adequate time to cover this important topic. So it looks like people are gathering in. I'll just take a minute and we'll get started.
We have to keep talking because if we stop, then they'll go back out.
They go back out.
Stay out. We have to start.
No, do you want to step?
Can I? I'm gonna.
I think he's good.
Nope. It'll
You
be
need to
better.
be on top of the world.
Dr. White stood on this and it'll be perfect.
Oh, this proves that my wife is right that I am shrinking. I've got vertebral collapse, and I try to, and so now these guys, and also this is a test of whether I get invited back. How is my ambulatory and neurological status? So Mo is checking out. And also, if I start getting into politics, come over, give me a shove. And it won't just be a shove to tell me to stop. It'll throw me off.
All right, everybody, good afternoon. Let's start again. Dr. Amsterdam, all of us know Dr. Amsterdam well, Director of Cardiology and Director of the Academic Program at UC Davis Medical Center, Professor of Medicine and Cardiology, and I invited him back not only because he's a great speaker and a great teacher, but the best teacher that I've had in my life. And I respect him regardless of his political views, as a father, honestly, for what he has done for me and touched me and how he has guided my career. So with that being said, Dr. Amsterdam, welcome again to Reading.
Thank you so much, Mo. That is a tribute that brings is very moving to me, Mo, and I cannot thank you enough for those kind words and for bringing me back. I always look forward to this meeting. I love it. I am impressed at the way you've reestablished cardiology here and the way you pack the house every single year. It's pretty fantastic what you've done, and we are so proud of Mo. And my wife also said, when I left this morning, she said, keep the politics out of your medical lecture. So I will do it. We had a little bit at lunch. It was it fired up a little bit, and that was good for the soul. So I see you had a previous talk that was around this topic, and I'd like to ask, Mo said I could do this, I'd like to ask if there are any questions lingering, because this is a very complex, if not to say very controversial topic, as you'll see as we get into it. But are there any questions now that we could start with? It'd be kind of nice to sandwich questions in between the two presentations. So anyone have any questions out of this so far?
Yes.
The question about the beta blocker, the 5 years. Can you hear me? Oh, there we go.
Well,
5 years on beta blocker and the increased incidence of hyperglycemia and diabetes.
Oh, okay. So did that come up in the hypertension
That
talk?
came up in the hypertension.
Yeah.
Dr.
Okay.
Amsterdam was referencing cholesterol.
I
but go ahead.
was, but you could ask questions about anything, and that could get us into politics. So there's also something about the way Mo set me up here. It's very ego depressing balances his great comments. As I bend down here, there's a picture of me here, and definitely I am bald. I can't deny it. I cannot deny it any longer. He got me. Okay, but that's a very good question because it does fit in with lipids, the beta blockers and hyperglycemia, you know, the metabolic effects of beta blockers. You know, it's like the small incidence of diabetes that can occur with statins. If those drugs, say beta blockers, are given to the appropriate population, the beneficial effects, RCTs, randomized controlled trials, clearly show the beneficial effects when given for the right individuals, the right indications, override the potential adverse effects. So if you take a beta blocker, you're not automatically going to get diabetes. There is also can be a small reduction in HDL. There can be an increase in glucose intolerance, just like with thiazides. So overall, though, those drugs, when given for the right indications, are beneficial and reduce the events that they're given to reduce the events. In the person, say, who already has metabolic syndrome, has a low HDL, an elevated triglyceride, has some glucose impairment, glucose intolerance, but not diabetes, fasting glucose 100, 105, 110, that would be a person that would be not a good candidate for a beta blocker because of the already risk of going on to full-blown diabetes. However, if it's a person who's had an MI and has a reduced ejection fraction, that's a very high-risk individual, and the beta blockers reduce morbidity and mortality in that population. So there you have evidence. We just went over evidence that, let's say, beta blockers are beneficial to prevent death in post-MI patients, but they can cause diabetes. So that's the evidence. That's the science of medicine. How we apply that science in individual patients is the art of medicine. And that's a decision the physician makes, clinician makes with the patient. And also there's a lot of emphasis now, particularly in the new lipid guidelines, cholesterol guidelines, about physician, clinician, patient interaction and discussion and engaging the patient in the decision on which drugs to employ. So I hope that gives you some idea. It's not absolute. It's not black and white. Take a beta blocker, you get diabetes. It increases the risk, very small. So are there any other questions? That's a very good point.
New research for interventions for pediatric cardiology?
What about pediatric cardiology?
Any new research?
Oh, in pediatric cardiology, I'm not a pediatrician, and I'm not aware directly of new research in pediatric cardiology. No, it's and that's an area when we have general meetings, there are always questions like that. What about the kids? What about adolescents? And I'm certainly not well versed in that. Happen to be very interested in screening of the adolescent and young man for athletic contests. And that's a very controversial issue. That's a work in progress. Some of the European countries do absolutely screen with ECGs and go on and do echoes. We do not advise doing that. And there continually to be working groups. Is it cost effective? You screen literally hundreds of thousands of people to detect one potential risk person. Cost effectiveness comes into it, and then it becomes philosophical. You're talking about a life, you're talking about possible sudden death, and that goes on. We don't do it in this country. It's not in the guidelines.
But I'll hold on to that thought. It might be a great idea to get a pediatric cardiologist to talk to us about pediatric cardiology. We'll make note of that.
Great comment. All right, so we can start on the discussion that we're going to have here. The new guidelines, and Mo put the subtitle, Help or Hindrance. And these are the new cholesterol guidelines we're specifically talking about. And I added to it, because this is a practical tutorial, I put another subheading, Practical or Impractical. When one first looks at the new cholesterol guidelines, that's all we're going to talk about in the new 4 guidelines from ACC-AHA. And you've also heard about hypertension, which is a 5th guideline, but not from the ACC and AHA. It's very political and very interesting, just the way there are 3 prongs to that new guideline. But practical or impractical. When one looks at the new cholesterol guidelines, I don't think there's much of a risk in saying the first impression is very impractical. What are they throwing at us? Because they're not evolutionary, they're revolutionary. You know, we'll talk a little bit more about that. But first I have to disclose, some of you know my feelings about this, and that's the only thing you'll know about them, okay? So, all right, now, this is something we attribute to Eugene Brownwald, the guru of American cardiology. He has, every couple of years, he publishes a review in the New England Journal about the history or the current status of cardiology in the United States. And this is one from late 2000, or from 2012, where he looked at the line, the brown line is indicating the course of mortality in this country, deaths per 100,000 population, from 1950 all the way up into the 21st century where we are. And he indicates very important milestones in the history of cardiology in this country. And they are pertinent for whether you're doing a heart failure talk or a electrical, an EP talk, or risk factors. The first thing we note is that since 50, there was kind of a leveling off. If you go back to the beginning of the 20th century, mortality from cardiovascular disease was going up, 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 and then it kind of leveled off, and then that 1970, 1960 is the point of the plateau. And since then, mortality from heart disease, which is still the greatest cause of mortality in this society, has gone down, down, down. You'll notice my skill on the computer, which I have very little of. I plagiarized and I doctored this. You see the line where the color changes a little? Because this is pertinent for today. But if I hadn't pointed that out, you would have never known how I did that. So let's look first at the points that are pertinent for this talk. Let's look first at, I have to be facile with this. Let's look first at an important area in risk factor history. Back in the early 1960s, that's when the risk factor concept was really clarified. The Framingham study had been going for almost 20 years at that point, and they were identifying back then, before many people in the room were born, I was already late middle age or part of the elderly population at that time. So I really remember this. So this is when it became finally recognized, hypertension, high cholesterol, et cetera. They were the things that give us, lead to arteriosclerotic vascular events. So that was that time. The first statin-type drug, the HMG-CoA reductase inhibitors, they are the statins. The first one was described by Endo, a Japanese company, in 1976. We didn't get these into practice in this country until the late 1980s. And the National Cholesterol Education Program from the NIH started in the mid-80s. That was the first ATP3, or National Cholesterol Education Program, number one, where there were some guidelines put out. There was still a raging controversy then. Is cholesterol really a guideline, or are we misleading ourselves? We should be focusing on platelets and fibrinogen. Cholesterol is a conspiracy between the drug companies and academia, the doctors, academicians to get more money for research, and companies to make more money. There still was a risk factor hypothesis, the cholesterol hypothesis. Then, and this one, I twisted it around because we're now dizzied. We're now dizzied by the new prevention guidelines. These are some of the big milestones, and you can see a lot of other things are associated with, or if not contributing to this continuing decline. But these new guidelines are really a total revolution, because the NCP 1, 2, and 3 said, oh, the cholesterol should be total under 200. Oh, the LDL, there's such a thing as LDL. That should be under 100. Oh, wow, we've got new data. That should be under 70. It was kind of a gradual, continual evolution. This is a revolution. And that's what we're going to cover. And I apologize for redundancy if it occurs with the prior talk, but I like to think of, at least myself, I'm a slow learner, and if I can get a talk given at the same time kind of repetition or some reinforcement, I consider it positive. Reinforcement helps me a lot, so I hope it does for you. Here's an impression that came with the new guidelines. This is from the New York Sunday Times a few months ago. Check your pulse. If you have one, you should be taking statin drugs. Should we put it in the water? You know, all the cliches that go with that. And it was at this time that Dr. Rita Redberg, a friend of mine, the editor of, it's now called JAMA Internal Medicine, used to be called Archives of Internal Medicine, a very good journal. And she's a cardiologist at UCSF. And she was quoted in the New York Times when these guidelines that came out and said, the only people that are going to benefit from these new cholesterol guidelines are the people who run the drug companies. Very strong statement, but there were statements on the other side. The expert, so-called expert panel, when we do guidelines, we call ourselves experts. That's where the expert panel comes from. So I'm now an expert. I'm co-chair of the new non-ST elevation acute coronary syndrome guidelines that we hope will be out in the next couple of months. We've been working on them for 2.5 years. And finally, I think we're done. So since I did that, I must be an expert, self-styled expert with all humility and modesty. So that's how that goes, the expert. A bunch of guys and girls sitting around a table saying, I think this is good. I don't know. Yeah, maybe we should do that. Okay, that's a class 1, means should do it, works. Recommendation for the guidelines. Class 1, level of evidence C. That really means girls and boys sitting around a table deciding this is a good thing to do. I'm being facetious, but be careful when you look at the recommendations for any of the guidelines we have. Obviously, you want to look at the class 1s, but if the class 1 recommendation is a C, it means we have no evidence. It's what we decided on the basis of experience, consensus of experienced people who are considered expert in the field. So we want class 1A. That means we've got hard evidence, trials, science. Class 1B. Not as much hard evidence as the A level of evidence, but there is evidence and there are trials. The C, for instance, you'd give penicillin for pneumococcal pneumonia. If the infectious disease people were writing a guideline, that would be a class 1C because there's no clinical trial. So the C's aren't always bad. For instance, if you put a ball on top of a hill and push it and it goes down, you don't have to do controlled trials for that. I'm all in favor of controlled trials, but some of the things have evolved over experience. So the C's aren't always bad, but be careful. We have a lot of C's and we want more A's, at least B's. So here, is this showing? Or, oh, okay, up here the top is cut off, but not there. Okay, good. So here's the old data that gave us the ATP3 Adult Treatment Panel, or NCEP, National Cholesterol Education Program. They're the same thing. That LDL cholesterol is closely related to coronary heart disease events. You know that. But this is some background. Coronary events on the vertical axis in any of these trials, and all of these acronyms are trials. This is the primary prevention curve over here, the top one, and the, secondary prevention, and here is the primary prevention curve, and here's the level, LDL level on treatment. And so you see, let's say for the AVCAPS trial, here is the on treatment, and it started way up here, the cholesterol went down, and there's a small drop vertically on events. That's not a high-risk population. Get to a high-risk population. The 4S trial, which really put the statins on the map. So here we have 4S. Up here is the pre-treatment, the purple, and then down here is after treatment. So cholesterol went down, the LDL cholesterol went down, and the events went down over here. And we learned from those trials that for every 1 mg% lowering in the LDL, there was a 3% reduction in total events, mortality, MIs, PAD, angina, all of those, stroke, they all went down. It was the average of all these trials. So it looked good. And you're going to see that it's considered that there's no evidence that the level that you get to with treatment really relates to the benefit. And that one puzzles me, because as we go down more and more on the LDL, the coronary events go down more and more. So this is one of the things that came up, that the expert panel, the guys who made the guidelines here, by the way, I was a peer reviewer for these guidelines, so I'm biased, because when I read them, I made some obviously detailed comments, but my overall was, this is too complicated, and the primary care doc, many of whom don't even use the Framingham risk model, which is pretty simple, 5 risk factors. Most of you do it on, if you do it, you do it on your phone, on your app. It takes 30 seconds, and I'm not good at computers, so I always race my colleagues and do it with a paper and pencil and see if I can get there first, even though I don't know how to work an app or a computer. And that was pretty simple, and it's not done by most. This is certainly not going to be done by hardworking, busy PCPs, even though I will acknowledge, if you do it, you know it, and do it over and over, it's very simple. So let's see. So these guidelines were based on the ATP3, NCEP3 were based on all of this wonderful data that moved us down into 70, LDLs of 70 and lower, and dropped, this is the percent decrease, not the absolute number of events, percent. It's the percent decrease. They were all very consistent. And the cholesterol hypothesis was over, because the cholesterol fact was now in. So here's what the panel got together, and we've been waiting since 2002, over 10 years, and came out with the new guidelines and the questions they asked about. Do we treat to LDL targets, you know, under 100 for this group, under 70 for that group? And they said, the randomized controlled trials do not indicate what the target should be. I'm not smart enough to figure that out from the slide I showed you, but there was no, clearly, it was the amount of reduction and the drug that was used. There was no target that got you the amount of reduction. There really wasn't a clear relationship there. There was a general one, but not a specific one. They also said that the magnitude, the degree of risk reduction of arteriosclerotic cardiovascular disease, we're going to use that, ASCVD, arteriosclerotic cardiovascular disease. It used to be CHD, coronary heart disease, that we were involved with in these trials. Now, a new thing that you'll see is overall vascular events. The big addition was stroke to the risk. That the magnitude of the additional risk reduction with one target versus another target, how much risk reduction you get if you do LDL under 100 versus if you get it under 70, that was a big thing for us. If you've got the disease and you've had an MI, we should get under 70. It really wasn't clear that that did better than under 100. So that was another confusing. And then they said it is unknown what additional adverse effects one gets from multi-drug anti-hyperlipidemic therapy to get to those specific goals we were using, like under 70. We had to pour the drugs on. It wasn't always a statin that did it, or a big dose of a statin and adding ezetimibe, or adding a fibric acid derivative. So that was unclear. And then there was the benefit was unknown from a treat to target approach, and as all of the previous 3 tell us. So they said, we're going to go by the evidence, and that really shrunk down what data there was available. No more possibilities and hypotheses. We're going to go by the evidence, and if there's no evidence, then we're not going to make a recommendation. So you'll see that they were not purists in that. They did go beyond that. We like things the way they were. And it's hard for us to change, particularly when the way we were was working. So how many of you, look at Redford, he's wrinkled now. He's over, and he doesn't get a facelift. And Barbara Streisand should treasure this picture, because she never looked so good. So how many of you have seen that picture, that movie, The Way We Were? Yeah, so that just reveals your age. You just did that. Okay. It's a secret, sneaky way, you know, to do that. But very, very sentimental, very romantic. It was a very good movie, and it really did portray the nostalgia we have for something that is working, and now we're wrenched away from that. So the process that we're going to talk about is not perfect, whether it was the previous process or this one. We work very hard, and I have friends who say, you guys don't know what you're doing. 1 minute, this was one of our female friends, she said, 1 year you're telling us to take hormones, estrogens, after menopause, and then all of a sudden you make a 180-degree turn and you say, no, they're harmful. What the heck is going on? And it's very hard for the public to understand. This is not Ayurvedic therapy or herbal therapy or the traditions, and I don't want to eschew those. They have a role, but they're static. This is the way it is, like a religion. Whereas with medicine, we try as hard as we can to be scientific. And the research is churning away all the time. So, and you know, science is modest. When you get the, well, I better not go there. All right. Let's put it this way. We have things that are hypotheses. Evolution is what? The theory of evolution. It's not an absolute, it's a theory. It fits what we know better than anything else we know, but it's still a theory. It's not an absolute. So not until we have conclusive trial data or evidence can we really be clear on something. So the process, we do work hard. We have a lot of things that are a work in progress, but the process, we make it as perfect as we can, but it's certainly not perfect. We do the best we can. And then I just did a very bad thing. I did, Mo. Okay, I know, my life is in my hands. I can't blame the projectionist. How did I turn that off? All right, okay, thanks guys. Okay, so I've mentioned the word evidence. It's evidence. You know, by the way, all the advice about taking estrogens, and it's going to protect women because that's what protects women from, gives them an advantage over men in terms of heart disease when premenopausally estrogens are there to protect females. So let's give estrogens afterward. There were almost 24 trials that supported that. None of them were randomized, controlled trials. They were all observational. And it was association. The women who took hormones also did they were the ones that also did a lot of other things. They didn't smoke, they had a good lifestyle, and so they did better than women who weren't on hormones, who didn't have as good a lifestyle, and that was consistent. Once the controlled trials were done, then the real answers came in. So science changed everything, and one should be glad that we do that. We go for hard evidence, and then we change our guidelines. In the absence of evidence, then we get to expert, level of evidence C. We decide. So we have to be a little modest about that. See, I told you, girls and boys sitting around a table thinking up these things. It's not quite like that. I'm being quite facetious. But we don't have evidence for everything. Now, we have 4 new ACC/AHA guidelines, American College of Cardiology, American Heart Association. We have the blood cholesterol, obesity, healthy living, and risk assessment, and there is a blood pressure. That comes from a variety, 3 different sources. It's really amazing the politics that went into that. It's not ACC/AHA. ACC/AHA came out and endorsed its 2003 statement to say we stick by our old guns, so they like it the way we were, but they are working on an updated one. But this is going to focus totally on the cholesterol guidelines. So the new cholesterol guidelines, and we'll go into this a little more detail to try to make it very concrete. 4 major statin benefit groups. I'm sure you went over that in the previous talk. The expert panel found, and this is how they changed it. They had both extensive and consistent evidence to support the use of statins. And that's how statins became the only drug that gets clear-cut support. And those showed that there are a lot of high-risk people for primary prevention who benefited. Remember, primary prevention means one does not have clinical evidence of arteriosclerotic cardiovascular disease. Hasn't had a stroke, hasn't had an MI, doesn't have angina, doesn't have claudication. but could have risk factors. And then all the secondary prevention individuals, people who have had an event, a stroke, a heart attack, have peripheral arterial disease. And this is very important because now we start to get into the qualifiers and the things that make us scratch our heads and say, well, is this guy really somebody? Should she really be getting this? Got to make sure she doesn't have even mild as well as severe heart failure, because there's no data in those populations that the statins did benefit the patient. Or they're not on hemodialysis. These are very high-risk patients, the chronic renal disease patients. And they have a lot of vascular events and accelerated coronary heart disease, accelerated atherosclerosis. But we don't have trial data that shows statins help these people. So if one wants to give it, one is doing clinical investigation. But that's a clinical judgment. You may say, well, I don't need evidence here. The risk is so high, I feel that the patient should have the potential benefit of the statin, unless you find the evidence that says it hurts them, and we don't have that evidence. But it made clear where there was evidence for benefit and where there wasn't. So there are other changes in the new cholesterol guideline. There's no LDL target. Now, I'm sure you're hearing this again. You heard this earlier today, right? Yeah, good. And, you know, I have a lot of trouble absorbing a lot of detail if I'm sitting out there. So if somebody goes over it again, I actually don't mind. Limited to, if it's primary prevention, not person who's had an event, to age 40 to 75, and LDLs of 70 to 189, because that's where the trials were. Why not in 76 and 80-year-old people? They were excluded from the trials. And that's something we need to stop doing, because the population is getting older and they need to be in the trials. When we did the acute coronary syndrome guidelines that I mentioned a little while ago, it's a paucity of data in the elderly. And one of the things, you know, one of my favorite topics, and I've spoken about it here, is women and heart disease. Women are not in a lot of these trials. Why? Because women get many of the diseases older than the age cutoff. You guys get the disease later. It's one of the things I like to say when wear red for women in February. I say wear black for men any month of the year, because we get the disease faster, younger than all of you. Obituary column. He is survived by his wife. He is survived by his wife. Good. Now, I read the obits not to make sure I'm not in there, but because they're wonderful biographies of people, particularly the New York Times obituaries. You learn so much about our own history and what people contributed. And you go down there, he is survived by his wife. Okay, Joe Smith contributed here. He is survived by his wife, et cetera, et cetera, et cetera, et cetera. Come on, you guys have more than a 5-year longer lifespan than we do, and it's getting even worse. It's getting even better. And I know there's giggling out there because many of you are freed after we're gone. The responsibilities, the double work you do, it's never 50-50, you know. Life is hard for women. Life is hard. Life is hard in general, but in the females, I think, have it a little tougher. So no measure of follow-up. You don't measure the LDL. You're going to see some of the consistencies here, because there are some things where you do measure the LDL. So they weren't pure. It adds stroke to the risk estimate. Addition of lifetime risk estimate. In other words, for the middle-aged people, the 30-year risk is, you can say, lifetime risk. And for the younger, it's meaningless to do the Framingham, a 10-year risk in a 30-year-old. It doesn't matter what their risks are. Age is the single most important risk factor. So if you're 30 years old, you could have the worst risk in the world. You're still going to be very low risk for a fatal or non-fatal MI in the next 10 years. So now we have a 30-year risk. I always said that wasn't a big handicap of the old Framingham, because you could show a person who was 35, smoked, had hypertension and wasn't getting treated, didn't want treatment. You say, okay, your 10-year risk is very low because you're 35 years old. Let's look at it if you don't change. Let's go to 45 and recalculate Framingham. 5 risk factors. Takes 30 seconds. Oh, it's somewhat higher now. Let's do it when you're 55, 20 years later. You didn't change. You're still smoking. You still have high blood pressure. Oh, wow, it's double what it was, et cetera, et cetera. So I didn't consider that a big problem. You could just show the person what was going to happen. He wasn't as immortal as he thought because he is going to get older. The risk is going to get higher. So, but this gives you an automatic. Diabetes, no longer a coronary equivalent. It is now back to a risk factor, which it was before NCEP3, the one in 2002 and its update in 2004. The prior NCEP2, diabetes was a risk factor. Now it's back to a risk factor, an important one, but it doesn't give you the same risk as having an avascular event. And HDL and non-HDL cholesterols are not considered. We have no data. We have no data. We know if you normally have a high HDL, a good HDL, that's a good risk factor for you. But we have no data that if you raise the HDL artificially with the drug, it helps. Just like we know that the best blood pressure, systolic blood pressure, is about 100 to 110. But we have no data that if with a drug you lower it to that, it does you any good. In fact, we have data that it does you bad. And you've had a good hypertension talk, and I wonder if he confirmed that or not.
Question.
Question in the middle. I'm on a roll. On a roll, man.
Well,
Yes.
I want to catch it while it's hot.
That's good point. Very good. Very good, Mo. This is great. And better for you guys.
The American Diabetes Association conducted a very nice study, the East-West study, looking at non-diabetics at risk of their first heart attack and looking at patients who had an event. And they were very equivalent. And that's where the notion came up that they are coronary risk, and the ADA still feels so.
Yes, very interesting. That was it was a study. It came out of Texas Southwestern and Europe, and exactly what Mo said. So just to repeat it, if you were a diabetic, you had the same 7-year. They did a 7-year follow, 7-year risk of having an MI as a person who wasn't a diabetic who'd already had an MI. His 7-year risk, her 7-year risk was very high at 7 years to have another infarct. And the diabetic who never had known coronary disease, the diabetic 7-year, you're not supposed to actually say diabetic, you're supposed to say diabetic patients, 7-year risk of having an event was exactly the same. So that's one study that made this a coronary risk equivalent. One study. Now, there's a lot of clinicians out here, and I'll count myself, and we have a lot of diabetics, type 2 diabetics, 90%, more than 90% of diabetics. And I must say, in my experience, that has not been fulfilled. And there was a lot of gossip in the last few years that that was going to be dropped, including by the ADA, which it wasn't, but it certainly was dropped here. And that gossip came true for the cholesterol guidelines, but not for the ADA. It's based on one study. I mean, if you had 100, just off the top of your head, 100 diabetics, not primary, but secondary diabetes, type 2, not type 1. Do you think that in 7 years there would be a high rate, as high as if the patients that had MIs have another event? This was all done too before therapy, before statins, before aspirin, before systematic. You know, it's much less now because of systematic therapy. You think that? My impression, and it's always dangerous because we have biases, and I just don't think that holds true. I forgot the guy's name. I always block on his name, the guy at Texas Southwestern who was the leader of that study. And it's not been confirmed. They are high-risk people, no doubt. I mean, it's the only risk in the new diabetes. Yeah, thanks for that, Mo. It's the only risk that if you have this single risk, then such and such, you go on to further evaluation. So it's not trivialized. It's just not given that high on the marquee. Really, really good point. HDL, LDL, HDL, and non-HDL not considered. And then high risk, instead of 10% risk of an event in primary prevention, 10% risk of an event in primary prevention. The new risk equations, risk estimator, is 7.5% or more. That is not evidence-based. So they made a big thing about evidence, but then they picked 7.5%. If your risk in primary prevention, means you haven't had an event, is 7.5% or more of having an atherosclerotic event in 10 years, then that puts you at high risk primary prevention in the category to get a statin, either a high intense or moderate intense. And no consideration, I said, of non-statin drugs, but they're not pure on that either. And so, bunch of things, and probably not the only ones. Okay, now the statin benefit groups, just so we remember them. I need some help. I already put arteriosclerotic cardiovascular disease. That's one. They need to be treated with a high-intensity statin. Give me another one, please. Don't, you know, if I know it's really hard. I do an EKG course in Hawaii, and I call on people, and if they don't answer, then I start going around the room. All right, we're going to start here. And somebody wrote in the evaluation, very nice session, but I came to Hawaii to relax. I didn't come to Hawaii to be stressed and called on. It was very good for me because I'm not going to do that to those people anymore. It's very high stress out there. So I'll say anyone who would like to, that's fine. But if you don't, then this is Hawaii. I'm not going to do that anymore. So you know, when you give feedback to Mo about the meeting, it's very important. It's used. We use it for all of our meetings. We use it for the medical students. You should see what they write. Boy, it's anonymous. And then we get them when they come on the wards because they're 100 strong out there. But when they come back on third year, and then we have them, we've got them. They're actually a very, really wonderful group. They really are. It's more than half women now, and they're just great. They're enthusiastic. They're sensitive. I need some help here. Don't be afraid. There are two. Say that again? Dialysis patients benefit? They don't. They're the group that there's no data for that shows benefit. That's what I said before. So that's why it shows that reinforcement is important. It's all right. So diabetes, if they have diabetes and are 40 to 75 years old and the LDL, and I don't say 70 or more to 189. Forget about the 180. Very few people have more. You don't have to remember that. If it's greater than 70, fewer numbers to remember. And a 10-year risk of 7.5 or more %, they now meet the threshold for a statin. And this is primary prevention, people. They don't have the disease. So you'll see, we're going to match the risk with the statin. So they're candidates for an intense or moderately intense. So positive means they have diabetes. Now, why is it 40 to 75? It's irritating that they put that in, because that's in whom the trials were done. There is reason to the madness here. So it helps us. I'm an angry person, and when I see, what, 40 to 75, making me remember all these numbers, I get angry. So I say, but calm down. Take a few breaths. That's who the trials was done on. And so they're not going out on a limb. Although, remember, guidelines, the operative word is guide. Person over there said the hemodialysis patients need a statin, and I said that. They are the ones that are the highest risk. There's just no data that the statin benefits them. But as a clinician, if you feel their risk is so high and they've even had an event, absolutely, absolutely. You can always, the clinician and the patient. It doesn't mean fly in the face of all the guidelines. It means use those guidelines with your judgment. Okay, now we're on the track. We're on the track here. Does anyone have? There's one really easy one. Yes?
Fatty liver?
To give statin? Fatty liver is one that makes you cautious about giving a statin. Somehow the data is coming around in reverse. You have to be very cautious if there's liver disease about giving a statin. I want the statin benefit groups. That's a very good point, and we need to take that into consideration. I want to know the ones that get benefit. There are 4 groups. Well, arteriosclerotic cardiovascular disease, you can't cheat and use it. I gave you that. but that shows listening. That's good. I think I heard something. Yes, there are two really easy ones. One is arteriosclerotic cardiovascular disease. I mean, stroke, PAD, aneurysm, aortic aneurysm, MI. That's an easy one. You don't have to remember numbers or age. And then there's the LDL 190 or greater. No age, no nothing. They are candidates. Now, I want to emphasize this. Always lifestyle changes. You go first with lifestyle, and they may improve their risk profile. Now, the ones that doesn't have diabetes, again, 40 to 75, LDL 70 or greater, and you calculate the you calculate the 10-year risk and see what they come out with. If the 10-year risk is greater than 75. The risk equations will do that, you'll see. Now, the LDL 190 or greater. So the 1 and 4 are very easy to remember, and then you just have to just put a little bit in your body. You know, it doesn't mean you don't do a 39-year-old or a 77-year-old. We can't be rigid here, but it's good to have this as a frame of reference. So now what we're going to do is put these with the statin. Okay, so the data, we're going to go with over 21 years old, screen for risk factors, measure the LDL, and if the person has arteriosclerotic vascular disease, diabetes, age here, I'm putting it in a system now where we will have these that we're going to fill in now. It's the same thing I just had. The two are on the end are easy. The ones in the middle are the things I just showed, so repetition. And then no data for patients with heart failure, New York Heart 2, mild to severe, and no benefit known for dialysis patients. So now we're going to match them. Arteriosclerotic vascular disease, high intensity statin. What is that? That's the Rosie and Atorva. And they theoretically give a 50% reduction at these doses. That's theoretical. Those of us who have used these, either the patient's not taking it or the trials overestimate. But that's what you can get. And you can give 80 here, and you can give 40 here. So those are the intensive treatment statins. And that's what you give for arteriosclerotic vascular disease. Of course, as was mentioned, if the patient has a fatty liver or liver disease, there's caution. Put the brakes on. Do we want to do it or not? It's one of the things you consider. Okay. Let's go now to the other one, the LDL 190 or greater. High intensity statin. What are those? Atorva or Rosie. And by the way, I didn't get my syllabus in, too overwhelmed with things, and I apologize for that, but anybody who wants them, I will send them to Mo and his staff, and I think he'll send the syllabus out to them.
We will, and these talks are available online. If you go to my website, they can listen to you.
Oh, wow. Okay. Oh, I like that. My wife says, you like that, right? You like to get that, you like to get the kudos. All right. So now we go to diabetes, age we've talked about, the LDL, 10-year risk. We calculate it. We'll see about how we calculate it. If the risk is less than 7.5%, they get a moderate intensity statin. If it's high, rather 7.5 or greater, a high intensity statin. What's the high intensity statin or moderate? Prava and Pitava, Simva, or the high intensities. So there are the statins. Now we go to our no diabetes. We calculate the 10-year risk. Again, same thing, moderate or high intensity. The clinician makes the judgment and goes with the moderate or the high intensity. Now, how do we get this 7.5%? It was so easy with ATP3, pencil and paper, male or female, age, smoking or not, HDL, total cholesterol, systolic blood pressure, and then you added up the points. The women were on one side, the men's score was on the other. And by the way, even though people say Framingham underestimated risk in women, that is absolutely wrong. For fatal and non-fatal MIs, it did not underestimate. And you could see, I love giving that talk because I take the same risk factors. The points add up for a female. They're a fraction of the points for a male until the age gets over 70. Then the curves get very close together. And you look and you knew the 10-year risk. It was very easy. But nowadays, I'm crippled on the computer and on this. I have a lot of assistants at the office that really help me, but you guys know how to do this. So very easy to look up right here, the box. You put ASCVD risk estimator. You don't have to be a member of the American College of Cardiology. You just put this in your address. This page pops up, and then you can go to any of these on the bottom. The one we're going to look at is the web version, and we're going to make this a female. It's a female. She's 50. She's white. Systolic blood pressure. This is not very different than Framingham. Smoker, treatment of hypertension, diabetes was not in the Framingham, because if a patient had diabetes, they were already a coronary equivalent. And then you have that, and then she needs to come out with somehow the slide for her risk is, we'll do it, oh, here it is, I'm sorry. Here it is, 0.5% 10-year risk. She's in very good shape. And 0.8% with, see, it's blurry up here. And now this is where Mo is giving me a big challenge. 0.8% with, we need up here, the 0.8 right there. With, now here, so it's 0.5 risk, calculated risk, and then right below that it's risk with, right there, 0.8, right to the right. Yeah, 0.8.
Optional risk factor.
Yeah, with optimal risk factor, and you'll, I'm sorry, with optional. Optional, and you can add other risk factors that are not in here. You can put in things like C-reactive protein, coronary calcium score. You can put in a variety of other things, triglycerides, and you can put in LDL, and you can change it. But this woman is in pretty good shape. Here is her lifetime risk, 27%. That's a 30-year risk. And here it is this is optimal, with optimal risk factors. And we'll see the optimal risk situation. So you can tell the person what their 30-year risk is. So 30 years, 27%, that's under 2%. That's barely over 1% a year. That's not high, but that number itself seems high. You can put in, this is frozen, so you can put in, but you can put in on your app, male, etc. You can fill these in. And then what you get also is you get a summary of what you put in, and then not in the statin benefit group because her risk is less than 5%. So she's less than 7.5%. And then here are the additional risk factors you can put in. You can read through here, LDL cholesterol greater than 160, the high sensitivity C-reactive protein, etc. And then you can get references. The clinician can go to the variety of references here, really great website. And then there's another program, the clincalc.com, that some people like better. And you can go by category, A to Z, by date. And this is very nice because you can get the CHADS-2 score for AFib, CHADS-2 VASC, the digoxin calculator for heart failure and AFib. Has bled is a very important risk calculator for atrial fib, because when you calculate, we use the CHADS-2 VASC to see what the risk is for a stroke in people with AFib, but then calculate the has bled. As the risk for stroke goes up, so does the risk for has bled with anticoagulation. And you're caught between Scylla and Charybdis. That's a little reference to the Greek classics for those of you. Scylla and Charybdis. Usually we say a rock in a hard place if we're not showing off. So now here's what we're interested in, the pooled cohort. These are the risk equations for the 10-year risk assessment. And here, the person, this is a different person, gets a 10-year risk of 8%, still pretty low, and, but over 7.5. And a 10-year risk in a similar patient with optimal risk factors is almost 40% lower, percent of a percent. And here are the optimal risk factors. It's a very good thing to know. The total cholesterol under 170. The HDL 50 or over, females 40 and men. Systolic blood pressure 110. But that's not with treatment. If we try to do that with treatment, we hurt people. That's if you take salt off the table, don't eat the vegetables that I grew up on, because my mother worked hard. She didn't have time to do things with fresh vegetables. She used canned vegetables, and when my wife started using fresh vegetables, she said, these are no good, they're tasteless. My mom used canned vegetables. I want canned peas and carrots, Crasdale, you know, all that stuff. I grew up on that. They're loaded with salt. God bless my mother, she worked very hard and didn't have time for all the niceties of cooking, but she could make some wonderful things. Okay, not taking medications for hypertension. See, this is intrinsic blood pressure, not on medication, not a diabetic and not a smoker. And then you could even add things with physical activity, does 20 to 40 minutes at least 3 to 4 times a week, and that's optimal. So these are really fantastic. And now it becomes a little less hard. And we'll show you some examples. Okay, so the ASCVD risk interpretation, the previous slide, that person has an elevated more than 7.5 for ASCVD in 10 years. So consider a moderate to high intensity statin with that risk, 7.5 or higher, assuming no ASCVD or diabetes, because that puts them automatic, and that they're age 40 to 75, and the LDL is 70 to 189. And again, you don't have to be a complete prisoner of that. Somebody's 38 or 77, or the LDL is 68 or something like, you know, you've got to deal with the individual patient. Okay, so an individual is not receiving cholesterol-lowering drug, then they didn't qualify, recalculate every 4 to 6 years. That's every 4 to 6 years, not every 4 to 6 minutes. We don't keep the guy there in a chain and keep drawing his blood. So we tend to over-test. This is a guideline in general. A person puts on a lot of weight in a year or two, you know, or things like that happen, start smoking, you'd recalculate earlier. So this is kind of an approach. So I thought it was not going to be used. I was negative in my review to the ACC and AHA on this, but one has to be fair. So elevated risk, moderate statin, and not receiving. Now, the statin battle. Now, this will get you out of your somnolence, I think, because this